Hi, welcome to On Becoming a Healer. Today we're going to be speaking about international medical service. We have a remarkable guest, Dr. John Lawrence, a pediatric surgeon, past president of the board of directors for the United States section of Doctors Without Borders, also known as Médecins Sans Frontières. But before we talk about John in particular and learn from him, I'd just like to ask my co-host Saul Weiner, what made this topic seem like a good fit for On Becoming a Healer?
So, Stefan, I met John just a few months ago at an alumni event at our school, medical school, and I was immediately struck by his story. We started chatting. He was there with his wife, Leola, and I learned, of course, that he is a surgeon and that he had recently returned from Gaza, where he'd been caring for patients. He's actually a pediatric surgeon, as you mentioned, but also a general surgeon. And then as soon as he got back, I found out that he went off to South Sudan. And so I was like, oh, and then his wife was rolling her eyes like, oh my gosh. Because obviously, what's that?
Oi.
Yeah, pretty stressful if you're the spouse. And so anyway, and then I learned that he is a past president of the board of Doctors Without Borders USA. And so, and what struck me about him was just how kind of laid back he is and nonchalant about all of this. And, I've been thinking about where our country is right now. This is a time where we're particularly xenophobic and isolationist, and things may well get quite a bit worse. And we also have done a number of episodes on how medicine in the United States has become increasingly profit-driven. And so the decision of an American physician to go and care for people in another country where there's an intense need and poverty is in some ways the antithesis of all of that. It's the antithesis of being a xenophobic. It's the antithesis of being isolationist.
Yeah.
And it represents a commitment to health equity, to public service. And I think those are characteristics that are very much intrinsic to John. Now, I also think we need to not glorify the idea of going abroad. It's not always noble. It's certainly never profitable, but it's not always noble. We know that American physicians sometimes go abroad and they may do more harm than good. We know that trainees may go abroad and be inadequately supervised and not benefit from it or do more of the harm than good. It can make people's egos feel good, but they don't do a lot of good. People can go abroad and not get a lot out of it. So it's not something that is just by definition a great thing to do. Now, I do think that a lot has improved in recent decades. Stefan, of course, as you know, you and I met in medical school over 30 years ago when we were on an elective together in Gabon, Africa, working at the Albert Schweitzer Hospital. It was an incredible experience for both of us, both positive and not so positive. But, it started for me with just finding a flyer in my mailbox and basically said, do you speak French? And if so, and you're a medical student, dial this number. And so that's how I got there. Now, these electives are much more structured. The AAMC has guidelines for what a good international experience should consist of. And so things have improved. But I do think that the opportunity to talk to somebody who's made this a major part of his life, who has taken on major leadership, is really special for us. And so that's why I thought it would be really great for us to have a conversation with John at this particular moment in our history.
Yeah, I really appreciate that. And I think, we're going to keep coming back around again and again to what do we get right? What do we get wrong? Both for the people we aim to serve and for ourselves and for our trainees. But I'd like to say a little bit about John that goes further into his life history because I think it's worth knowing. John is from Illinois. He attended Dartmouth as a college student. In college, he volunteered in a number of places, a Job Corps center in Montana. He taught English in a Vermont prison. He worked as an assistant counselor in a methadone maintenance clinic, an issue close to my heart. And as a first-year medical student at Dartmouth, he wrote letters around the world to see if he might do a rotation overseas. He landed a spot in Johannesburg, South Africa. That was the one that responded to many, many letters. And then he actually went back for 5 months in his fourth year. After completing an internship, he served as a primary care doctor for 4 years at the Navajo Reservation in Tuba City, Arizona, later doing general surgery residency, pediatric surgery fellowship, and he's been a practicing pediatric surgeon for a full academic career, recently retired. But along the way, there's been a long series of surgical or medical missions to places all over the world, up to 25 countries, maybe more, including sub-Saharan Africa, Haiti, Syria, recently 5 weeks in Gaza and 2 months in South Sudan. And John has served as the past president of the board of directors for the United States section of Doctors Without Borders from 2016 to 2019. And I just want to say, Welcome to the podcast, John.
Well, thank you very much, Stefan. And it's really a pleasure to be joining you today and to have an opportunity to provide a little perspective on some of the issues that you've already brought up, or that you and Saul collectively have brought up, not the least of which is kind of our evolution as a country, how we're viewing foreign engagement. I think also, as you've already started to unearth a little bit, this whole process of becoming a healer is very much what got me wanting to be involved in doing international work. And so it, in so many ways, ties together very nicely. And as I say, it's a pleasure to be here.
Yeah, we are really happy. So with you here, I kind of wanted to understand from your history, it sounds like you always wanted to volunteer. It's not like something about international service made you develop a heart for this. So I'm wondering, who were you in college that you were seeking these opportunities to serve? What was going on for you then?
Yeah, I would answer that by saying, as I look back on it, I'm not sure there was this abiding desire to do volunteer work, but it was one of the extracurricular activities when I was an undergraduate. And, it's already been alluded to that I was a native of the Midwest. Sometimes people make the joke, the only people that live in the Midwest are people who haven't been elsewhere to realize, that there's other parts of the country and the world and what they offer. But there was maybe a measure of truth in that. I didn't really have much in the way of travel exposure or much interaction with much of the rest of the country growing up. And so when I had gotten to Dartmouth, one of the first open houses they had for extracurricular activities, what's now the Center for Social Impact, and that in that era it was called the Tucker Foundation, had an opportunity for working on a Job Corps center in western Montana that served Native American youth. And the opportunity to go there had appealed to me, as I think I'd had an interest in Native American culture prior to that without any realization. I actually, at that point in my life, thought I wanted to be a math teacher, and it seemed like a good way to get some experience being a math teacher, because that was one of the subjects that was taught on this Job Corps Center as part of GED training for the individuals who were attending it. So there was a bit of serendipity, I think, is what I want to interject in all of this, rather than a design. And when I got out there, it was very eye-opening. I mean, this was a population that I'd not had much exposure to, and a lot of disadvantaged backgrounds that these individuals talked about. We spent a lot of time together, both in the classroom, but also I had the opportunity one day a week to go out into the vocational training projects that they were engaging in. So heavy equipment operating, forestry, truck driving, mechanics. And so it was there was really a good chance to get to know these individuals, not just as students, but in a more holistic way. And part of that was learning or hearing many stories that they told about challenges in healthcare that they or their families had experienced. And that was then kind of the sort of inflection point in my own career of, well, maybe being a teacher isn't what I want to do, and a math teacher in particular, but maybe going into medicine is something that would have perhaps a greater impact.
At a certain point, I should stipulate, you also want us to underscore that you didn't actually graduate from college. You went to medical school without graduating. Is that right?
is correct, Stefan. Yes.
My parents would be shocked. They might even disapprove.
I just have to interject that I think it's worth sharing with our listeners the story, which I think is hilarious, which is basically that he had already gotten into medical school. He was working at a methadone clinic in New Jersey and was just having such a great time doing it that he realized, he had one course in social sciences that he needed to take to graduate, and it just wasn't worth it. He just was like, I got into medical school and I'm learning a lot here in New Jersey, taking care of these people who are struggling with drug addiction, and what the heck? And so I think that says something about his personality that I actually think is wonderful. But I think he was counting on getting that social science course in sometime in the last 50 years. And he never did it. So he still does not. He still has an asterisk.
There's
still
plenty
time.
of
He still
time.
has an asterisk next to that.
Yes.
Yeah, he still has an asterisk. Now that's something you could do. But anyway, he still has an asterisk next to that. I think Dartmouth is proud to own him, but he does not have that diploma, at least from the college.
Yeah, thank you for that storyline. Yes, as I said, my parents would be shocked. I do want to ask, you went overseas early on as a medical student and then a second time. And I have to ask, what was the impact of that on you? Like, did you think, Jay, this is cool, I just want to do more of this? Or was there something more involved there? What happened as a result of going to a vulnerable population, perhaps in a African country?
Yeah, well, in a lot of regards, Stefan, it was really a transformational experience. So I would start out by saying, prior to making that trip in medical school, and some brief trips into Canada, but I'd never been outside of the United States, and so there was the element of being in a foreign country for the first time, but much more was and I would just sort of add to that. I originally went over to study nutrition, so I'd had this interest in nutrition, and that was the assigned spot that I was supposed to be was in a metabolic unit, that they called it, but it was a research lab that was studying various nutritional deficiencies. But there were quite a few South African medical students that I very quickly met there at part of the University of Witwatersrand. That was one of their big teaching hospitals. And they said, shortly after, meeting them, it was, well, what are you doing here? And after I explained I was studying nutrition, they said more or less, well, that's not very interesting. You ought to come out in the wards and experience interactions with patients. And again, this was a different time. I know that for medical students today, they often have some introduction to physical exam in the first year, history taking. I'd had none at that point. So The first time I ever put a stethoscope in my ears was, listening to a child with rheumatic fever in the pediatric ward there. And kind of getting back to answer the question, though, of, kind of the, what were the impacts? So I certainly got the sense of what a difference there was in terms of healthcare equity, right, for the population that was being served in this hospital. And you could see, certainly in the city of Johannesburg, the general hospital serving European populations, totally different landscape. But, as importantly, and one of the things that was very influential from that experience was actually getting exposed to the bedside teaching rounds. That was a very firm tradition in South African medical education at that point in time, and really stemmed out of what I think more broadly is the European system, where the rounds would be made at the bedside, a history would be presented, then the medical students in particular were supposed to demonstrate the physical exam on the patient. The professor would be there and would critique both the history and the physical exam as it was being performed, and then there would be what they would refer to as tuts, which was short for tutorials, and they would talk a little bit about the specific entity that the patient had. And so it was a wonderful introduction. And what I realized, though, and the reason I went then back for the 5 months in my fourth year, is that I couldn't really fully benefit from this experience, and that once I'd had some clinical training as a medical student here in the U.S., I would really be able to take advantage of that opportunity.
It sounds like it awakened you to something. Would you say that this then spurred your later overseas service?
Well, absolutely. And the way that it did so, and we'll kind of just continue on the story now. So for my fourth year, when I did go back, it stands to this day as the best education that I ever had at any point in my life. So this formalized system was just, very different than what existed in I think I would say in the U.S. at that time. There was very much this Socratic method of questioning and dialogue that was part of that. But moreover, it was an opportunity to get involved in hands-on care, doing procedures, and really having the opportunity to get much more kind of clinical experience than I could have imagined would be possible at any point for a medical student anywhere as far as that goes. It was very routine for the South African medical students, at that time, though. And I could give you an analogy of placing a chest tube or a thoracostomy tube, the sort of thing as a student in the U.S., I dare say, would rarely be capable of performing or allowed to perform. And there it was another medical student who showed me how to do that in the course of a rotation. So I came away with this, what I thought was really a great educational experience, but realized at the time that this was very much self-serving. So I was taking a great deal of knowledge and expertise away, but not really contributing very much. And in my mind, thought this would be, at some point in the future, I'd really like to have the chance to reciprocate for this great experience that I received in a setting that was clearly of high medical need.
So, John, one of the things that I'm thinking about as you tell this is what you would consider a good learning environment for a medical student today who is on an elective. And, one of the things that you describe, and that I actually experienced when I was a fourth year medical student, is that when I was in Africa, I got to do procedures and things with a degree of autonomy that would not have been permitted in the United States. Now, one could argue that that was great for me. One could also raise questions about whether it was appropriate if, on the other hand, it was outside of the scope of practice for me in medical school in the United States.
Yeah.
Now, and so I think one of the reasons that medical students often like to go and work in international settings is in the hope that they will get clinical experience that they couldn't get at that stage in the United States. On the other hand, it also raises potential ethical questions about whether that's appropriate. And yet at the same time, they may be doing procedures and providing medical care in areas where the alternative would be no medical care. But on top of that, no medical care is probably better than bad medical care. So, you can see that there's this kind of thorny ethical quandary about what the appropriate opportunities should be for a medical student in an international setting. So I'm wondering if you could just comment a little bit on that from your perspective.
Yeah, absolutely. And I think it's a great issue that you raised, Saul, and it really is a fine line between having enough supervision and in turn maybe being, to use a phrase, in over your head in terms of what you're doing, which can have certainly some very serious negative implications. But to kind of tie this back into actually a rotation at Bergwanath Hospital for about 6 weeks on the OBGYN service. And so I went during the day a couple of times, and somebody there said, well, you ought to come in the nights because that's when we really need the most help. And so I wound up coming in one night, and there was I'm going to guess he was, a registrar was the term they used, but probably the equivalent of a third or fourth year resident, who every night was covering all the deliveries as well as all the cesarean deliveries. And that unit did, I think, 60 or 70 deliveries a day. So every night he was doing 6 to 8 cesarean deliveries by himself with just the nursing staff to be able to help. And so to have another set of hands available to kind of speed along the work and make things better for him, he was ecstatic to have me come. And in turn, what then happened over the course of this 6-week time was the ability to progressively do more kind of hands-on suturing and at a level that I just don't think would have been practical elsewhere. So there was some value I provided to the team collectively in their effort to expedite their work. Now, to kind of talk to the issue of perhaps inadequate supervision, fortunately, that was never the circumstance there. I always felt like there were people around that if myself as a student or other students were doing something, we could find someone who could kind of correct our problems, as it were, in real time. But by the same token, there was just so much to do that if a simpler task could be accomplished by a medical student, that was invaluable to the greater collective effort.
So I think what you're saying, to summarize, is that sort of the happy middle place is a situation where a medical student is genuinely needed, is well supervised by an experienced clinician who is probably a local person, might be an international as well, and has high volume, and is able to supervise, and just creates a situation where that medical student can progress at a much more rapid pace than they could have at most American hospitals, just because of the difference in staffing. So that's kind of the happy middle place. I think the unhappy situation is one where the medical student is taking on responsibilities, or any trainee, it could be a resident, is taking on responsibilities without that level of supervision because there's no one else to do it, but without assurance that they're doing it competently.
Correctly.
Yeah, exactly.
Yeah, absolutely.
So, John, as time went by, I mean, you developed your career in the United States, but it sounds like you also took on a series of, I want to use the word missions. Is that the right word when you went overseas?
I mean, I think there's a lot of terminology that could be applicable here. I think there's a tendency to associate the word mission with religious-based work.
Yes.
And what I would say is, I have a tremendous admiration for, religion-based healthcare that's provided internationally. It has not been a part of my own career or justification or motivation for what I do. So I think there could be assignments you could use as a word, volunteer work when that's applicable. But the term mission, to some degree, has a religious connotation, I think.
It's fraught.
Yes, which is not to say that is not a positive thing by any means, but just doesn't accurately describe my own work.
I've seen short-term international medical mission trips, or STIMMTSs, in the literature. It's a handful, or a mouthful.
STIMs.
Yeah, STIMs, or whatever you want to call them.
Yeah.
Yeah. So I think the term mission does not necessarily mean religious, and is used to describe. In its case, they can be short-term or long-term. One other thing that I'm interested in hearing your thoughts on, John, is the nature of the relationships that you develop with local clinicians. I think one of the things about going on a mission is that you don't want to do it as if you've kind of come from the moon or dropped off of been dropped out of a plane, and you're just there, and all of a sudden you're doing your thing and then you leave, because you're entering a culture, you're entering a community, you're entering often a functional health system, or maybe a system that is quasi-functional, but has real people in it who are trying to do their jobs and who often know their jobs very well. And so kind of entering into that with humility and with the recognition that this is an opportunity for a sense of shared humanity, for getting to know each other's expertise, for entering into a community. I would love for you to talk about that, because you've had so much opportunity to do that over the course of your career, and the risks of not doing that.
Yeah,
it's a great topic to touch on, and it also ties a little bit into my own personal story. So the first experiences that I had internationally, now after having fully trained in pediatric surgery, I think would identify being very much in line with what you were alluding to, Saul. So they were trips of 1 to 2, maybe 3 weeks with a variety of different groups in a variety of different settings, but in a less structured and more kind of sporadic environment of dropping in, I think is maybe the phrase that you used. And one of the things that I found, and I'll say a little frustrating at the beginning of my career in doing these, was that invariably it seemed like members of the medical staff, hospital administrators would always want to have a day or two to meet, to talk, to go out to dinner. And it struck me as kind of some degree a waste of precious time, as I traveled all this way to do medical work, and here we are just socializing. Now, as I think about it, from the perspective of those people on the ground, and very much what you were alluding to, I think, Saul, of if you turn this around and somebody in their U.S. practice had someone drop in and say, I just want to work with you for 2 weeks, I think everybody would say, well, what's the motivation of this person? What are they, what's their intention, their skill set and experience, all these things. And so in many ways, it's very natural, I think, to, want to understand better what is going on in the mind of somebody who's doing sort of sporadic work like this. And I think it also, those early meetings with, various people in the community also, I think, probably serve, though, as a effort on their part to provide a bit of a cultural introduction. Here's the context that we're working in. Here's what we're experiencing. And to some degree, probably steering us into a channel that they think might be the most viable way of utilizing our skill set versus what we may have come predetermined to do. And as I'm talking about this, one of the things that, working then with Doctors Without Borders, which is the group that I've worked primarily with over the last 15 years in international settings, there, the experiences that I've had was much more of a what I'll call kind of plug and play. So it would mean you'd go into a spot, there was already an established project, there had been surgeons working there previously, someone would leave, and I would then take that role and kind of fill in. So there was a much more momentum and kind of structural understanding, I think, of what the role was and what was to be accomplished, and already this dialogue interaction with the local healthcare system having been established.
And how do you weigh, we talk about using your time, which is very valuable when you're only there for a few weeks. How do you weigh providing direct care yourself versus training other surgeons? Can you say a little bit about that? Because that's one of the ways in which you can kind of leverage your expertise in a longer term manner.
At this point in my life, and I would say that for me, the real value in these settings absolutely lies in incorporating capacity building in what you're doing. And to some degree, I think that will happen, almost by default. I think it's part of every medical practitioner's experience, no matter where you are, is the potential for capacity building, right? So whether that's educating patients, educating, staff members, students, or formal learners that may be with you, there are things that can be acquired all the time just by the simple process of being in the presence of someone providing health care. But to do that on a more formal basis is something, I think it should be very fundamental on international efforts, because this idea of dropping in and providing expertise is great in small measures, but so much better if you can, leave a skill set in the people who will be staying in that country to perpetuate, what it is that you may have accomplished clinically. So it's not always possible if you're in a conflict setting, and again, working with Doctors Without Borders, it really hasn't been feasible many times, or there aren't learners formally present in these settings. But I think ideally, that's where the ultimate benefit, I think, of having somebody coming and providing outside expertise really lies.
I wonder if you could just give an example of a situation where, large or small, you felt like you kind of did add to some aspect of local capacity.
Well, I could go back to my most recent experience in South Sudan and working in a rural hospital there with Doctors Without Borders, and there was already an established program that is overseen by the faculty at the University of British Columbia in Vancouver, and their program is designed to provide a surgical skill set to non-surgeons who are from South Sudan, who would then be anticipated at some point in the future to be working in a more rural or isolated clinic or hospital themselves, and would have, first of all, greater understanding of surgical disease, but actually a bigger part of this program was formal training in a subset of procedures that would then allow them to not have to refer patients to a facility with a formal surgeon, because the numbers of surgeons in South Sudan is so limited. So that is an example of something I was involved in. Another one with Doctors Without Borders was in Liberia, where again there was the intent to train both surgical residents and nurse anesthetists in pediatric surgical or pediatric perioperative care. And the surgical resident part never really got off the ground, but the nurse anesthetist training program was, I just think, incredibly successful. And even though I didn't impart any anesthesia knowledge myself, but colleagues who were working in this program did a great job of taking, and again, there were, at the time when I was there in the 2016 to 2020, I guess, that I went multiple times, there were no anesthesiologists in the country, and the nurse anesthetists were all trained at a single school and didn't really have a separate curricular element in pediatric anesthesia. So their ability to work in our hospital that had a high volume of pediatric surgical cases done was invaluable, and leave those individuals then the skills that they learned, will stay there in Liberia. And so, that's another example where I think you really, yes, there's the patients that you've provided care to and served that, hopefully improving their health outcomes, has been an important element of what's transpired. But I think that educational piece perpetuates the value of what you may provide.
I want to ask about potential negative interactions or miscues of expectation between the community that receives the visiting clinician and the community there.
I would say that the questions I've seen come up in that regard are probably stem, more on the individual circumstance of what does this, individual who is clearly not from, our country, what is their intent? And I'll just kind of give you a concrete example so it's a little less vague. So individuals that have had serious traumatic injuries and require an amputation, and many times the process of bringing them to the conclusion that they need an amputation done because of severe soft tissue injury, loss of vascular supply, whatever it might be, that's usually not a great discussion for me to be having as the individual making the main push for that. I often think that is better done by someone who understands the cultural context of what that means, who is familiar with the dynamics of the cultural interactions or social interactions, and has the language skills as well of the patient, which many times I'm working internationally relying on translators. So I think suspicion or hesitation in that regard exists, and I think though that you're bringing up, Stefan, another great point that I think is worth tying into this discussion, which is many times international people go with a skill set of here's what I can provide, but that does not necessarily coincide or mesh with what either the patient population or the local healthcare providers feel is their greatest need. So it's a little bit of if you have a hammer, you're looking for nails to pound in, but that may not be. In fact, it may be a series of screws that need to be put in place with a screwdriver. And if you didn't bring a screwdriver, how do you make that all work out? And there's a very poignant example of that. I think that Doctors Without Borders experienced with an Ebola epidemic in the last 3 or 4 years in the Democratic Republic of the Congo, around the city of Bunia, where they came in and they said, we're here, we want to provide treatment centers and vaccinations and eliminate this epidemic. And the local population's sentiment was, that's great, but we want primary health care, and we want obstetrical services, and we want a more basic package of care. And they really couldn't implement the Ebola treatment in that community until there was also kind of an agreement reached with, we want to make sure that other health services receive attention while we're kind of here in the spotlight, rather than choosing what you've selected as our highest priority.
Yeah, that really speaks to what I was trying to get at. I had written to myself a question about the difference between moving into a disaster and doing an immediate intervention versus what might be called a slow-moving disaster or a slow-moving situation of deprivation, and where the community just doesn't have what ideally it should have for blood pressure care, diabetes diagnosis, whatever it is. And I wonder, have you been in situations or have you seen others successfully renegotiate to address slow-moving disasters?
Well, I think that I'm going to just sort of rephrase what you're bringing up here, I think, Stefan, which is to say, when you are trying to, import healthcare expertise, where is the most value added? And preventative health is really where the sort of greatest added value comes. So water and sanitation, vaccination programs, and then, as you were alluding to, primary health care. So there's kind of this glitzy, we did a complicated surgery on this single child, isn't this remarkable? And there's value that's provided in that, but probably in almost any setting, there's more value from making sure that there's secure food sources and there's clean water and there's a means for managing waste, and that basic vaccinations are being delivered. So always I think there's this potential for what a given community needs and what an organization may be bringing in, and sometimes these things can be done in parallel, and not a sort of an inherent conflict in doing that. But I think other times there's a potential for outsiders to prioritize something that may not be the needs that the community themselves or that the local healthcare providers or healthcare system feels might be the most valuable. And how do you reconcile that? Hopefully it's through a dialogue. As residents from someplace internationally coming into a given healthcare setting, I think it's important to have humility and a desire to have dialogue about what are the needs perceived, and hopefully being able to address those or find a means to tackle those.
Because you've been in Gaza so recently, and because it's such an area of international concern, it would be great if you could tell us a little bit about your experience in Gaza. What were you doing clinically while you were there as a surgeon? And tell us a little bit about what you were seeing and what that was like.
My experience in Gaza doesn't necessarily or shouldn't be reflective of this is what everybody in every part of Gaza is experiencing. So, but the time I was working there, we were working in a field hospital or a hospital that was basically had been constructed in the last few months. That was all in tents. And I was working with the group Save the Children International, who were interfacing with UK Med. So as a pediatric surgeon, the role was in theory to be available to take care of inpatients who were mostly trauma patients. But the hospital was really not very often a primary trauma facility. It was actually the bulk of the patients they received were patients who'd been cared for initially at another facility that was very close by, and then they would offload more stable patients who still needed surgical care or surgical expertise. So they weren't people kind of fresh coming in with severe injuries. So that was part of what I was doing. And then another part was there was a very busy outpatient clinic that was attached to this facility. And so probably in the range of 200 pediatric patients a day from the community, and the community being largely a tent compound, and tents would even over-exaggerate the level of shelter that many people were living in. It was more wooden sticks and tarps and blankets that were serving as their residences. And this was in the humanitarian zone known as Al Mawasi. And so there were some pediatric surgical acute cases that would come from there that I would consult on and care for. But then also, another part of that was there were quite a few patients who had received care in the healthcare system from pediatric surgeons, Gazan pediatric surgeons, who, once the war had started, now had no access to be able to see these individuals again for ongoing care. So there were a lot of complicated, neonatal conditions and other pediatric surgical conditions that don't necessarily get fixed with a single operation, where these patients needed ongoing care but didn't have a facility to go to. And on learning that there was a pediatric surgeon in that particular hospital, there were a fair number of those patients that came as well.
What kind of trauma were you seeing?
What I would say is, pretty typical from conflict zones. So it was burn patients, patients who'd had, shrapnel, explosive device injuries, a fair number with amputations, lots of fractures, and complicated open fractures and non-healing fractures. We actually had a very full complement of specialist orthopedic surgeons, urologic surgeons, I was an otolaryngologist that came through periodically in this hospital. So there was a great deal of support in that regard. And these are all individuals from Gaza. There were very few of us that were from outside of Gaza. But those would be the main injuries, or just the sorts of things that you see in any warfare setting.
What kind of surgeries were you doing?
There was a lot of wound debridement and wound management. So this is, again, a very typical in other settings I've worked in, where you just in burn care being another example of that, where the patients just need an every other day return to the operating room to wash out, to clean, debride an infected wound or what had been a dirty wound in order to get secondary closure. So those were the types of things that I was seeing there. There were a few, what I might call more standard pediatric surgical things. We did some hydrocelectomies and hernia repairs, which again is, you might say that wouldn't seem to be a priority, but again, this is one of the things I think that's sort of lost about care in conflict zones is, you need to also take care or try to take care of routine health problems as they come up, in addition to all of the pressure that the care of injured individuals puts on the healthcare system that tends to deprioritize all the other elements of routine health care.
And your experience could have been quite different if you'd been placed at a different hospital, much closer to areas where children were being affected by trauma.
Yeah. And really, it doesn't come down to distance. So we were probably as close to those patients. It's just that the EMS services were preferentially taking them to this other hospital, and where they, the things like a fully stocked blood bank had been in place for, weeks and so on and so forth, that prioritization made a lot of sense for the services that they had.
And what were the risks that you were taking by being there?
Yeah, the team from Save the Children International had a designated individual in charge of our security. And so what that translated to in very practical terms was, on a daily basis, communicating with COGAT, which is the Israeli government's kind of humanitarian coordination arm. And so talking with them about the route we would be taking each day to get in and out of the hospital, and when we would be leaving. And so our whereabouts were very strictly determined. And similarly, travel after dark wasn't permitted, so we couldn't leave before a certain time. We had to be back in our resident facility at a designated time. So, I personally felt quite safe in that regard. And our living compound, which we changed during the time I was there, just because the front of the war advanced from where we were initially staying in Rafah to necessitating us to move up to Deir Abala. But there was this awareness that I think existed on the part of the Israeli military of where we were at any given time, more or less. And so, is that an ironclad guarantee that nothing would happen? No, but it felt quite safe. I live in the state of Texas where, concealed carry of firearms is perfectly legal. And I'm more worried about, I think, things that could transpire in the community I live in a grocery store, in a restaurant or bar or school, heaven forbid, than I probably, would worry about in Gaza. So it's the unpredictable element, I think, of having, people who, in whatever way can be armed, fully armed, but have no idea who they are, what's transpiring in their lives at that very moment, versus this kind of scheduled, here's where we're going to be, the conflict is around us, but we shouldn't be affected.
Yeah, I think the point to be made here is it's not that Gaza is safer than Texas. It's that if you're in Gaza under the very rigorous security system of Doctors Without Borders, which works closely, in this case, with the Israeli government, and there's close coordination, that creates a kind of dome of safety for you.
But that leads to the question of, when you took care of patients, it sounds like mostly children, as they left your domain, did you have emotions about their potential survival or non-survival of what would happen afterwards?
Well, Yeah, absolutely, Stefan. And look, I think one of the great dilemmas, and I, would sort of say ethical dilemmas personally about working there is that, I realized I was existing in this very privileged bubble or dome is the words you use, Saul. But, the circumstances for me were very different than they were for the Gazans and even the other members of the healthcare team who were going back to their residences, but with no guarantee of protection or safety at a given time. And I think another part of that, though, that's very poignant and that's still, to some degree, maybe would just use the word troubling for me, is that the whole time I was there, I also knew I was going to have the opportunity to leave at some point.
Yeah.
And I think that's what's really unique and particularly tragic for me about the circumstance in Gaza is that the Gazans don't have that option. To leave the country, there were some that had the wherewithal to do that or the economic means and connections to do that, but the average citizen of Gaza don't have that possibility. And so it's, very unsettling. All the people that I met and worked with, what's their fate today? I don't know, whether that's patients, staff, and others. So it's...
Are you able to keep in touch with any of them?
So I have been communicating with actually a medical student who was my main translator when I was working in the hospital. And so I've been in touch with him on WhatsApp, and but otherwise have not been regularly communicating with others. Yeah.
What have you been learning about the people who you worked with and knew while you were there?
Look, being in the center of warfare is, when civilian populations are involved, is never a pleasant or desirable circumstance to find oneself in. And so the stresses that all these people are experiencing is very uniform, and the kinds of things that we hear about and read about, obviously that kind of potential for injury or the uncertainty about one's safety on any given day, challenges with trying to find food, clean water. Many of the people that I'd worked with, and not different than other residents of the country, had relocated to 4, 5, 8 different places in the course of the war there, as various safety zones were designated, mandating that they try to be in a spot that is deemed as safe as possible. And from as I was just alluding to this one individual, Mohammed, who was a medical student, besides all of these other issues, he has the uncertainty about when will my education resume again. And so, and that's something else that I think is particularly unfortunate part of the conflict, the interruption of education at all levels. Small children, on up to medical students are now have their education interrupted, and many of the universities or structures that house schools now destroyed, and so it's a very tragic part, I think, of the whole circumstance there. Not that there aren't many elements that are very sad.
So, John, I have to confess that in the 2 times that I've gone overseas, both times to Africa to work, I always had a notion of what I was going to be able to do. And somewhere around week 3 or 4, I would hit sort of a rock bottom where I realized that most of my expectations were not going to come to fruition. And then gradually would kind of recover somehow through some kind of human connection with people around me. And I'm just wondering if you've seen that before. Does that happen a lot, and how do people recover?
Yeah, and I think it's a very prevalent problem. And so it can be a matter of mismatched expectations, maybe from what one perceived before you left home to what an experience is actually like in terms of how much assistance one may be able to provide. I think it can also be, something that we're just touching on, the reality of how difficult the circumstances are for so many people in low resource parts of the world. And that's certainly from a healthcare standpoint, but from other parts of their lives. And then I think you also have another element that I think can really contribute to, despair being the word that you use, but are complications or deaths that you know would be entirely preventable in a high-resourced medical environment, and here you are because of lack of some ventilators or the ability to give intravenous nutrition or whatever it might be, somebody that you say this person could very readily survive if we had X, Y, or Z, but it's not there. And so the experience of having, elements of whatever term you want to use, despair, sadness, depression, anguish is very real, I think, and one that I'll just talk about Doctors Without Borders. They do a great job of, I think, trying to mitigate as much as possible. So it includes meeting with a psychosocial provider who's skilled and with years of experience working with healthcare providers working in international settings. So it's before departure you meet, after you return, you're also meeting with these individuals, and then actually a package of benefits for ongoing mental health care if you should provide to do it. So
wow,
that's one part of what they do, which I think is really very valuable. Another less rigorous is something called the peer support network, which is just somebody else who's done this sort of work in the past that then calls you up within a few weeks of arriving back in the country to say, how are you doing? So that in the network of people that do this regularly, there's also that ability to have somebody who is a peer to be able to talk with about these issues. But I think that bringing up the whole topic of mental health, I think it's such a fundamental part of what is probably there's not enough attention paid to on either side. So both for the patients that we take care of in these settings where mental health needs are so huge, but it tends to be not prioritized personally to the degree that I think it should, but also then for the providers themselves, making sure that those aspects aren't minimized or overlooked.
Wow, I really appreciate that. And I think it's something that isn't really brought up as much as I'd like.
For listeners who are physicians or other healthcare professionals who are interested, but who maybe find the idea of going to an under-resourced country a little frightening, but who want to make a difference, who want to do something, and let's just suppose there's some way in which they can free up their schedule. They're going to do it on vacation time, or they have an employer that's sympathetic and will give them some time off. So just setting aside those issues, what would you tell them?
That for me, first of all, it is a means to maintain the altruism, I think, that many of us go into healthcare for. I think there's a real mismatch that happens as from when people start medical school and what their motivations are and what they hope to be accomplishing in a medical career, and then what I might call the business or economic elements of healthcare that drive or put pressure on so many practitioners to a point where their satisfaction level starts to diminish. And so for me, this has always been a way to kind of refresh that element of why is it that I went into healthcare? It's that the simplicity, the joy of providing medical services to people who might not otherwise have access to them. So that there's something very fundamental, I think, or elemental about that aspect of it. It also is a great way to appreciate, what it is that we tend to take for granted at home. So that can be in our work environment of, I ordered the CAT scan 15 minutes ago, but it hasn't started yet. What's wrong the nearest CAT scan is 500 miles away. I don't even have access to one. So again, it just gives you a different perspective on what are real problems or settings where people don't have enough to eat. It doesn't really matter so much that your internet service is not going as quite as fast as you'd like it to on a given day. It does help modulate what are real concerns in life. But as to how to accomplish it, I would say by whatever means it's possible. The one of the great things about the time we live in is that there's now many online banks or repositories of opportunities of where one can work.
Yes.
And we've kind of talked about this before, some with religious organizations, some with non-sectarian organizations all over the world, different durations. Some may be a few days, some may be looking more for a year or longer, but the ability to find those opportunities is so much easier than it was 50 years ago, or almost 50 years ago, when I was writing letters to various universities to say, could you take a student? And I think it's just really a great mechanism, though, to counteract what is something that is so prevalent in our practices these days. And I'll use the common term burnout of, this is a way to offset what may become the very mundane elements of practicing health here in the U.S., that you kind of set aside all of that, and it's a way to revitalize or refresh, I think, the sentiments, the emotions, the motivations for what brings so many of us into the healthcare arena.
That's great.
Yeah, I really appreciate that. And it kind of actually, as I was re-experiencing despair I felt overseas, I also began to re-experience the hope and some of the excitement I felt as well, just listening to you. So with that, I want to say thank you so much for being on this episode. And Saul, thank you for helping put this one together.
And thank you, John.
Yeah, no, it's really been a pleasure and a privilege to join you. I must say the kind of perspectives and the investigations or topics that you're covering, with this podcast, I think are fantastic. And so I very much enjoyed being a participant here today.
Wonderful. Thanks.
Thanks.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app, as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.